Good afternoon to anyone who's in a UK time zone. Good morning, good evening if you're elsewhere. We're going to start in just 2 or 3 minutes. Hopefully you're all in the right place. You should be on the BMJ Future Health webinar on digital leadership in the NHS, how to develop a coherent digital strategy, digital health strategy for your organisation. If you want to make a quick brew, now's your last chance to do so. If you would like to introduce yourselves in the chat box, please do so. And we will be keeping the questions in the Q&A, so please use the chat just for introductions. Tell us where you're from so we can get an idea who's in the room today. And we'll start in just a couple of minutes. Okay, so we'll make a start. I see Charlotte's put an intro in the chat. Please do feel free to introduce yourselves in the chat. Let us know where you are and who you are. I'd like to introduce myself. So my name is Linda Vernon. I am the head of digital empowerment at Lancashire and South Cumbria Integrated Care Board in the northwest of England. I am a physiotherapy practitioner by background. And I now lead on digital strategy and particularly our digital citizen portfolio in Lancashire and South Cumbria. I'm your moderator today, and I am joined by two really brilliant guests who I'm looking forward to hearing speaking. The topic for today is digital leadership in the NHS, how to develop a coherent digital health strategy for your organisation. And as you can see from the charming photos on the slide, I'm joined today by Joe Harrison, who is the Chief Exec at Milton Keynes University Hospital NHS Foundation Trust, and Mike Bracken, Founding Partner at Public Digital. BMJ Future Health is a new community we've created that consists of a webinar series, which you're joining today, some podcasts and a live event in November, and we'll give you some details about that before we finish up for the day. We believe that innovation through digital solutions is now essential to creating thriving health systems that are financially stable, are also conducive to a very supported and empowered workforce, and deliver better patient outcomes and ultimately healthier populations. At the end of today's presentations, we will have some Q&A, so please do feel free to submit your questions in the Q&A section and not in the chat if that's okay, because it just makes it easier for us to navigate those questions at the end. You can keep any general comments in the chat, and as I said, do feel free to introduce yourself. We just want to remind you that the session will be recorded today and will be made available for watching afterwards. The webinar is going to explore the opportunities for the NHS in cultivating senior leaders who can drive digital innovation within their organisation, creating an environment that encourages innovation and transforming the delivery of patient care and operational functions within the health service. So it is my great pleasure at this point to introduce Mike Bracken, first of all, founding partner at Public Digital, who's going to give us the first presentation. So over to you, Mike.
Thank you, Linda, and welcome everybody. Thank you for BMJ and Joe and I think I'll take more questions later because we're accustomed to doing this together. Um, Firstly, I'd like to say, as well as thanks to everyone at BMJ, thanks to you for giving your time to this. Let me briefly introduce Public Digital. I'm a founder at Public Digital. We're a consultancy that helps institutions with digital change. That includes the NHS, NHSP, over 100 trusts. And my colleague, Chris Fleming, who leads our health sector, has led the product management of the first wave of the NHS app. He and his team have really helped us work with most parts of the NHS. I'm going to talk today a bit about leadership in general and digital leadership, not particularly about the details of the NHS. And I recognise we have from the helpful comments put in the chat, we have people with diverse backgrounds. So I'd like to sort of start with basic principles for leadership. I think these probably are good for any large institution in the internet age, and then talk a little bit about the problems facing health and the NHS in particular. The first thing to do, I think, the first piece of advice I would give it is this: the NHS, at a time of its institutional change, particularly with the change in NHS England, is at a fascinating moment, I believe, where it has, I think, belatedly faced up to something that many big institutions don't face up to, in that the market, what it calls a market for digital services, for technology and so on, isn't really fit for purpose. And regardless of where you are in most NHS, whether you're in primary care, secondary care, doing GP appointments, health records, there aren't really open, competitive, innovative marketplaces based around interoperability and standards and protocols. Where those markets take place around technology, and the internet generally has worked in that way, you then only get good at scale results. And the NHS doesn't really have enough markets to do that, which makes the job of leadership in the NHS, regardless of where one sits, all that harder. So I would suggest that the first thing any leader needs to do in the NHS is to firstly look at the state of the current supply base and the current installed base of its digital services and technologies, and ask yourself, how can I help lead through this, suboptimal position? I think the first thing one can do is be militant about interoperability. In the internet age, strength comes from scale. And what that means is if you share more, if you adopt common standards and processes and protocols and build on them, your work and your organization design, anything from your services you deliver to use internally, can scale exponentially. There are many, many things about the Silicon Valley platforms that I wish I didn't have to see, but one has to reflect that they have grown hugely on the back of a militant set of using protocols and standards. The NHS as an institution is big enough to do this, and big enough actually to export some of this around the world. And yet we are held back by this patchwork quilt of technologies and services sitting on those technologies which don't talk to each other and don't have scale. So I think it's the job of any leader, regardless of where you are in an organization, to agitate for and to be militant about using things that are interoperable and open. How best to do that is the question. And I think there's two things leaders need to do. First, you need to detach thinking from thinking about technology. Digital services and many of the services that we use are not in and of themselves technology. Yes, you might need some technology, but the NHS has had a pretty, like many big institutions, has confused the procurement of big IT with the delivery of digital services. And it's a job of any leader to stop that, to stop thinking about the answer to the problem being an IT system. Occasionally, you might need some. I suspect in the NHS, a period of turning off a lot of legacy systems is much more needed than buying any new ones. Because the idea that if you buy more and more of these, you will suddenly have a convergence, and that convergence will lead to the sort of wonderful era of great digital services. That never happens. So that model, which other institutions have tried and failed, it's always jam tomorrow. Just one more service, just one more big procurement. What we need to do is decouple those things and decouple technology and digital services. So it's the job of a leader, where possible, particularly being on things like procurement boards or management teams, when you're thinking about operating models, is to decouple the thinking from technology procurement. The next job of a leader is to create and empower teams. In the internet era, I believe that the most power and most scaled organizations, most changing institutions come from empowering digital teams. When I led the government digital service in the UK to create Gov UK and then reform dozens and dozens of services and the institutions that provide those services in the public sector, my job was to, as much as possible, push power and authority down to talented teams made up of mixed disciplines who collectively were closer to the problem. And that's going to mean some hard things for some people in the NHS. And the sort of playing the clinician card sometimes and saying, I'm more powerful than you, so I must have my way. That needs to stop. You having recognizing that people doing different jobs in different hierarchies are equally valuable in multidisciplinary teams. And it's the job of a leader to shape those teams and to empower them to make decisions, not to let them fall victim to the sort of hierarchy and organization design that the institution demands. So creating the space for teams, sometimes that's literally a space, getting them working together and focusing on the problems you want them to do, that's the next job. There's a big part of leadership is if you like demonstrable public leadership. And one of the things about leadership in public sector institutions is simple, which is usage and demonstrating the tools and services that you want to see, using them yourself. When I started the government digital service, this is a very old anecdote, but I used to send a video out to the 8,000 people in my profession who are scattered across the UK using sort of basic stuff like YouTube and elsewhere. And these things were banned in government departments. And of course, I sent them out, and everyone said, well, if this guy sitting in London can do this every week and talk to us, well, why can't we? And it's really incumbent on digital leaders to use the tools and demand better tooling so that other people can follow them. Like hiding communication in hard to read PDFs and so on is not good enough these days. One has to communicate using the tools you want to see and using the tools that most people use in their personal lives as well. So that's a sort of unavoidable part of leadership now, particularly in institutions which aren't all co-located all at the same time. Using the open internet tools to communicate is vital. And the final thing is very counterintuitive for institutional design. Most institutions work on a hierarchy, NHS is no different. But actually, in the challenges the NHS face, sharing is leading. So I talk to so many institutions who have separated themselves off from other trusts or even other parts themselves, where one wing is using one system, one wing's using the other. Having the courage to share and open up systems on an interoperable basis rather than buy specific bits of technology is a much needed form of leadership now in the NHS. And even if you're not in a position to make that decision, one certainly should be in a position to lobby for it. I think finally, what I would say, if you're not at the top table when key technology and digital service decisions are made, what you possibly are in a position to do is connect with your users of your services. And one of the things in a supply side economy like the NHS is we know our users so well, we think we can provide a service for them. But in a digital world, as we all have our phones and computers, our needs of our services and what we actually want from them change imperceptibly very, very quickly. So we're constantly iterating and changing our services. So it's really important to have a connection to users and to be able to see what they're doing, what's working for them, what's not working for them, and to be able to change quickly. Putting things into multi-year or several month change windows for small technology changes, that's not good enough anymore. And leaders need to be able to rapidly adopt to how users are using their services. And having those feedback loops to understand how people are actually using the services rather than how you want them to use them, that is a vital part of leadership. I'll stop there because I've taken too much time already and I'll let Joe go, but I'm happy to take any questions later on.
Brilliant. Thank you, Mike. I've loads of questions already, but please do, audience, please do put them in the chat if there's anything you'd like to ask Mike or Joe. Super. Okay, over to you then, Joe, for your overview on digital leadership.
Thank you very much, Linda, and thanks for that, Mike. I will build on a number of the points that you've made. I'm going to break my sort of slot into two, if I may. One is looking at things from a trust perspective, and being the CEO of Milton Keynes, and then secondly looking at the national picture, having just been the national director for digital channels looking after the NHS app. So two different versions, two different lenses. So here we go. Starting at the trust, it might sound easy as a chief exec to take your organization into being a digital organization. The reality is somewhat different, and there's just a few things I'll put out to hopefully whet your appetite. So digital will mean all sorts of things to different people. And we started off here 10, 12 years ago about saying, okay, how are we going to become a digitally enabled organization? And we broke it into 5 different sections. So to start with, what's the infrastructure you need? The basic wiring. We're talking Wi-Fi, we're talking basic systems that you can hang everything else off, your electronic patient record, that infrastructure that enables digital to work. And that's really sort of comfortably in most organizations in the hands of the CIO, the CTO, the people who are really great at the technical side of life. We then looked at 4 other domains, and this is really important when you start to engage the organization and map that into conversations at board and conversations throughout the organization. Those 4 other domains were clinical. There we're talking about what sort of med tech do we want available to our clinicians to enable our patients and to support the delivery of care. So coming back to Mike's point, can we buy really fancy bits of kit that can remotely report into the electronic patient record that support our clinicians doing their day-to-day jobs? If the answer to that is yes, make sure you go out and buy the right bits of kit, that it all works, and it's a single piece of kit that everybody in the organization has. It doesn't matter if you're in cardiology, respiratory medicine, it doesn't matter. You'll have the same device. So that clinical med tech is a big domain. Second big domain is around professional services across the organization. It's no good if all of your staff have to sit down and fill in paper statutory mandatory training, have to do paper forms for expenses, and look at every professional service that you provide and work out how to digitize it and make sure that those systems are connected, whether it's electronic rostering, connected to payroll, connected to expense claims, connected to, you get the message. This is about taking those support services and saying you have a role to become digitized. The 4th area is around patient facing, and we'll come more into that when I talk about the NHS app. And that is about how do you empower your citizens, your patients, to enable them to get involved as much as possible in their healthcare and make choices. I'll leave that one and come back to it. And the final one, which is really not often connected, is the delivery of estate and green tech. And the reason we went for that as the 5th domain, I'll give you an example there, is we've put solar panels all over Milton Keynes Hospital to generate about 15% of our electricity. And by doing that, we've enabled, from an HR staff benefits perspective, the opportunity for staff to get free electric car charging because it's coming from the solar panels. We've also then enabled the roofs to be kept in a decent state because they're protected by the solar panels. And so that virtuous circle evolves. If you can do all of your statutory mandatory training online, you can do it at home. It supports flexible working. It only really supports flexible working if the infrastructure allows you to log on anywhere in the world and do your emails, which of course we've got here without carrying a dongle around or whatever it is. You can tell I'm technical. So those 5 domains then enable a board conversation whereby you have 5 directors who are responsible for delivering digital access for staff, patients, citizens. It's not a case of everybody looking at the chief information officer or everybody looking at the finance director. It's about engaging the entirety of the board in conversations about how we move the organisation forward. And there are many boards that do have a CTO on there. I'm not for one moment saying that it isn't worth having as well. For me, this is all about an and. How do we ensure that every member of the board has a voice in how digital develops and coming from different perspectives? Linked into that, it is really amazing as a leadership team. It is incredible how much we don't know about digital developments. And by enabling 5, 6 people to go out and find out what's going on, you're automatically increasing the size of knowledge and the amount of knowledge in your organization. And it's legitimizing conversations for the estates director to come back and say, have you heard about the fact that you can do X or Y? You're legitimizing the HR director to talk about digital AI that can be mapped across into the finance team to support them. So that group model, for want of a better description, has been really important. If I then link it into the national piece, because there'll be people out there who aren't chief execs who feel like they are that middle management. And whilst the title of National Director of Digital Channels gives me a national director role, when you're caught between the Secretary of State and the service, you're very clearly middle management, let's be honest. And the big thing for middle management, wherever you are in your organization, is to ensure that you have sponsorship for the work that you're doing and to have that clarity of vision. Very simply, from an NHS app perspective, we are absolutely focused on giving the citizen their information in order to empower them to take the best possible decisions about both their illness and their health, and to actually focus over time that move to health management, not just sickness management. And that clarity of vision then enables contributions around how best to do that, what's going on globally, how do we ensure that the Secretary of State has a vision in terms of impact on health, understands what happens with vaccines and so on. And the ability for that middle manager and that middle management to enable the senior team to see where we want to go and to provide people with the information and knowledge to take informed decisions is really important. And we've seen that over the last couple of years, and we've seen how by putting technology in the hands of our citizens, we've seen adoption rates that I don't think we could even have dreamed about a couple of years ago. And seeing 1/4 of our entire adult population using the NHS app every month is staggering. And so we know it's possible. We also know it takes a huge amount of energy and effort. And there are also the big non-believers. And I'll finish by recognizing that as an NHS, we almost always spend 80% of our time on the 20% of the people who don't want to do things. When we're looking at digital innovation, it's critical that we flip that around and spend our time on working with people that do want to do things so that they can show people and evidence that digital innovation does work and does deliver a changed NHS and a changed experience for our citizens. I'll pause there, Linda.
That's fabulous, Joe. Thank you very much. So I don't know if it's just me. I can't see any questions in the chat. Marina, can you double check that I'm right there? Because at the moment I can't. And I suppose I've lots of maybe comments and thought in my head rather than questions. Because some of the things that both of you raised really resonate and I suppose related to a lot of examples locally as well. So just first of all, I think you've just touched on this, Joe, that the digital data and AI literacy, that's the way we're framing it in Lancashire and South Cumbria. AI is feeling like, you know, it's the golden magic wand at the moment that everybody's embracing. But actually, have we done enough? And I know the answer to this is no, but have we done enough to actually upskill, educate and inform, not necessarily how to use the tools, but how to understand the potential, but some of the limitations around AI. So we're framing this digital data and AI literacy to become a data enabled as much as a digitally enabled system. And I guess, you know, that has to be from ward to board or cradle to grave, whatever way that you want to frame it. Do you think, I know there's an NHS providers digital board piece of work, I think a program that supports boards. Do you think we could and should be doing more in that space, particularly with our execs, so that they really are understanding not only the potential, but some of the limitations? And I'm thinking as well around, you mentioned about green and net zero and green tech. We're also looking at some of the disbenefits around net zero of AI. So AI consumes a lot of energy, and how can we balance that? And we need our wider system leaders, estates, etc., to be part of that conversation as well. So I'm going to start there on literacy. Do you think we're doing enough with boards as well as with our frontliners in that space?
I'll start by saying I'm sure one of the reasons that I was asked to oversee the development of the NHS app is because I am completely digitally illegitimate. It absolutely hopeless. I can barely use a phone. And for me, I don't need to know how the AI in my car works. I just need to know that when I put my foot on the accelerator or brake, it delivers the product. And so for me, the senior leadership positions that we have in the NHS and in organisations must remain rigidly focused on the benefits of the product and not get into the weeds of the how. I think Mike made a really valid point earlier on about the putting very clear restrictions on what technologies can and should be let into organisations, the interoperability, and making sure that we don't have a proliferation of different systems. A combination of those two things, it's not, I don't believe for one moment that it is people's digital literacy that is preventing the NHS from moving into the say 20th century. I think we do need to move into the 20th century. One hopes that we can skip a century and move into the 21st. It is a fear of change. It is the behaviours and, in my view, the concerns and the risk-averse nature of using digital rather than the need to necessarily be taught how everything works. I'll finish by saying there's also a very clear recognition that this is not about increasing the digital literacy divide. This is absolutely about making sure that those that can in the health service and who are accessing the health service are able to do so, to enable those that can't, certainly in the short, medium term, to gain access. There are an awful lot of assumptions also that are being made about digital health literacy, which I think we have to quash as quickly as possible. I'm sure Mike has things to come in on as well.
You're on mute, Mike. I knew somebody would.
It's going to happen, wasn't it? Yeah, I mean, I can be possibly a little more bold. I think what I'd say to anyone in the NHS is, for very good reason, And too often I hear people say things like, well, how can we sort out the nation's problems of digital literacy? Number one, you can't. Number two, it's not your job. It's like, get back in your swim lane. Like, there's far too much of sort of going after national missions because we're a national organization. The internet's been around, the web's been around for 30 plus years. Most people can use it. Those who can't fall into two camps, can't and won't for different reasons, and they get help. But it really is massive overreach for the institution, the NHS, to start to want to sort of tackle these problems. They'll tackle themselves if you manage your data properly, if you publish to the web properly. Just, I mean, people want the nice, shiny new things. I get that. But actually, as an institution, set of institutions, we're often not good at the very basic things that have now been in place for 20 plus years, like making websites that work and that can be found by search engines. No one wants to go and do that now. It's not sexy, but that's the problem. The NHS, because of the sort of nature of some of the Landsey reforms and the institutional model, has a domain problem bigger than the rest of the public institutions in this country put together. So sorting out the domain problem would be a good place to start. I say this to most people and so to build on that theme, where I think all leaders of public institutions need to think about is the technology industry and its various pushers in the market do not help, because often what they'll say to you is, oh, you need to be good at blockchain, or Bitcoin's coming, will change everything, or etc. etc. Again, that is not the case. It's not the NHS's job to fall for the latest fad. AI genuinely is a paradigm shift in computational delivery, and that will make a big change over the next 20, 30 years. We are at the early stages. It's an emergent technology, and most NHS institutions I can see are miles away from even having the correct foundations to be able to take advantage of that. I wouldn't say I wouldn't bother trying, but it's sort of sinful to start messing around with emergent technology like AI when your website doesn't work properly. So let's fix that first.
Yeah, get the basics right. So there is a question in the chat around digital exclusion, digital inclusion. There's a question from Alina. In GP surgeries, we see patients split between digital first users and those who still rely on the phone. How should ICS digital strategies bridge that gap so innovation improves access for everyone, not just the digitally confident? So I know, Joe, I hear your point around if we actually design and engage all of those who can, we're still empowering not only our workforce, but our patients and population as well. But I guess with the risk of health inequalities widening, how should ICS digital strategies bridge that gap? Any thoughts from either of you?
Shall I go, Mike? So if we take the 8 a.m. fastest finger first, let's be clear: there are digital health inequalities at that precise point. There are health inequalities at that point. There are health inequalities when we ask individual citizens to come to outpatient appointments. If you're on a 0 hours contract, it's going to cost you an awful lot more money than it is if you're able to take half a day's annual leave and you're not on a 0 hours contract, or you're indeed able to not work. So there are inequalities built into our current system that we have to recognise. The key for me is to ensure that we both provide dual systems where it's required, and also use money saved from investment in tech where appropriate to support the development of those areas that need it. If I put that into English, it's very clear that we must not just implement an AI triage process when you phone your GP without individuals being able to speak to a human. That's not acceptable, because there will be people that just cannot find their way through it. We have to run both. Is it reasonable to enable people to choose how they access a service, be it through AI, through human? Yes, to a point. We have an unaffordable healthcare service at the moment where everybody is getting a poor service and everybody is treated as the lowest common denominator in relation to access and capability. We must lift people out and enable people to do where they can in order to free up. And I'm going to keep coming back to that, because the key for me is nobody overtly is recognizing the health inequalities of how we're making people wait, how we're treating people in our current system. And we have to be honest with our citizens that that's what's happening at the moment, and digital helps to improve that.
Thank you. Mike, do you want to come in on that, or shall I?
Well, yeah, I mean, there's a concept called failure waste or failure demand, which is how much time and effort institutions spend on essentially not getting it right first time, or not giving the optimum level of information or service in the first go. So the standard model is, you try it online, it doesn't work, therefore you phone up, and if that doesn't work, you turn up or write a letter and go into turn up on the doorstep. Now, we did a bit of modeling years ago, and there's basically a 5x leap in cost between the channels. So digital is like 20 pence per transaction, and the telephone's about £1 and so on. But what people don't see, and what you'll have in these units, is that there is someone on the receiving end of this input. So someone's got to look at the poorly filled in form on the website. Someone's got to take the ticketing system that the phone automatically generates and answer that ticket and look at it. There's a set of, there's energy and activity and attention that gets given to multiple requests, false requests, partly filled requests, and so on. The cost of that is vast. It's absolutely huge. Now, in most organizations, that runs somewhere between 20 and 40% of operational activity. And those figures are based from like years ago from studies of like HHS and places like that. I suspect in some of the trust it'll be more. So for me, you can use advanced tools like AI to go after that, but not necessarily to offer a service to people first time, but to do some analysis on where really the attention and the waste is going. And I think that's something that is probably more of a lucrative and better way of using technology than trying to sort of co-opt it into an already somewhat difficult service to use.
And I guess that speaks to your comments earlier, Mike, about user-centered design and actually getting as close to our users as we can.
Yeah.
Which I feel is one of the big challenges with any deployment, but actually with our citizens and public. The more we can work with those who will be using the tools, and particularly the people like Joe who admit that they're, not the most technically minded to start with, then we start to design services that are fit for everyone. I'm almost going to slightly challenge one of the comments you made earlier, Mike. You said that it's not our job to solve the digital divide for the country. I suppose I would say it's our job along with everyone else. It's third sector, it's local government, it's NHS. And I think there's a fabulous report that I've quoted so many times. Public Health Wales wrote a brilliant report on digital exclusion and health inequalities just at the end of the pandemic, around 2022, I think, and really trying to highlight the correlations between those who are digitally excluded, those who have less employability, those who have less earnings, lower earnings, lower educational status. And we know that those are the wider determinants of health. So I think there's something about how we collectively, and I guess this is in my system role where I see that we need to work collaboratively and not just in isolation in the NHS, but we can achieve more together. There is another question in the chat. So if anyone has more questions, please do pop them into the Q&A section. One's just arrived, but I'll do this first. So how well do you think we are doing at national and board level, striking a balance between recognizing the art of the possible or maximizing opportunities and the potential for unintended consequences and the potential for harm in context of, I presume that means the board assurance framework with control and mitigations? Joe, that sounds like one for you, maybe.
Thank you for that. So we've got 7.5 million people on our waiting list in this country who almost certainly we know that some of those patients will be coming to harm So let's have an honest conversation with the public about the fact that waiting causes harm. And let's then give the patients, potential patients, our citizens who require help, the opportunity to choose whether they wish to engage with digital solutions or not. Let me give you a really specific example. We've got 250,000 people on our waiting list at the moment, waiting for a dermatology appointment. We know, because the evidence is there, that somewhere between a third and a half of those patients will be waiting to see whether they have a mole that is cancerous or not. We also know that there is technology available today that can diagnose whether a mole is cancerous or not with better clinical efficacy than primary care. It's as simple as that. The evidence is clear. It's been through the MHRA, it's been through NICE, it is clear. And yet we don't make that technology available to our citizens to see whether they wish to get an opinion through technology. There are a number of other technologies available out there that could and should be offered to our patients to enable them to either wait better and wait well, or indeed be diagnosed and have their worries put to bed without having to actually see a clinician. So do I think we've got the balance right? Absolutely not. Do I think there's a desire to get that balance right? I can't say yes to that at the moment. All I can say is that I hope so. Do I believe that we have the appropriate risk appetite in the NHS with technology? Not a chance. And the other example I will use is Apple have spent billions, literally billions of dollars on their Apple Watch ECG. And yet we don't use it in this country as a medical device, and the US do. US, the most litigious healthcare system in the world, and we don't use it. I don't understand why we aren't in a position to take some of these amazing technologies and put them in the hands of our citizens in a constructive and helpful way to enable access. I hope we'll get there.
So Joe, while you've been speaking, Charlotte, who posed that question, has just clarified that in terms of harm, she was referring to things like AI hallucinations, EPR crashes, software updates, things
Brilliant.
that let you down.
Okay, so that's brilliant. I have the delights of saying I started my career in medical records when it was paper medical records. Everybody has forgotten the fact that in about 10% of all the consults, you couldn't get hold of the medical records. We expect digital to be 100% correct 100% of the time. And actually, our frame of reference must change to ensure that the digital options that we're putting in place should be better than the current system. And we must not wait until they are 100% correct. Otherwise, we'll never achieve. So all of those things happen, of course they do. We've forgotten that we used to lose 10% of our records anyway.
Mike, do you want to come in on that one or not? Shall I move on?
Well, I just to clarify the question, the question quite rightly, it was a very good question. It said, AI hallucinations, one shouldn't be using any form of AI that hallucinates in core medical systems, like full stop. So, I mean, I wouldn't. Popular retail services like ChatGPT have a place. They're very interesting in high take-up of users. They're not at all to be relied on and put into in medical systems. In terms of things like, and the other part of the question, like, can we use AI to look at tertiary data centers or something like that? You can say, can we use AI to ... nearly every question in the NHS? Mostly, you could say we could use pretty existing basic technologies that have been around for decades, do it better than we do now. Like, you don't need AI to sort out most of these problems. You don't need AI for me to upload my data from this device into my personal health record. You just need to sort of sort out some of the structural blockers in that system. And I think that it is perfectly reasonable in a moment, in a sort of societal moment of new technology to ask the question, should AI be doing this? But I think the prior question should we have sorted this out already with the technologies that are already
Yeah. Yeah, I totally agree. There are more questions about AI. So I'll go to one in the Q&A. So this is about primary care in specific. So AI triage working, so this is as opposed to AI standalone in a patient's hand. AI triage working alongside reception staff over the phone seems like it would help with the 8 a.m. rush that Joe referenced earlier. Patients who need extra assistance could be prioritized by reception, while others are supported through automated triage without waiting on hold. How widely is this approach being adopted in GP surgeries right now, and why do you think uptake is still so limited? I don't know if either of you have primary care thoughts and experience.
So I'm happy to take that. We know there's a pilot going on in Sussex at the moment, which has shown somewhere between a 40% reduction in calls received and a 26% reduction in the number of abandoned calls, and so the positive stats go on. That's come out over the last couple of months. We know that London are right on the cusp of doing the same pilot, same interest in putting it in. Coming back to Mike's point, I think it is really important where we are using AI and where we're using modern technologies, we iterate quickly. So nobody, I was talking to somebody the other day about this. Nobody would, if they picked up an iPhone 1 now, nobody would say that's rubbish, it was a complete failure. Because Apple are clever enough to market their next phone, their next bit of software as a development on from. And that's what all good companies do. In the NHS, we go, well, that was rubbish and it failed, we're going to do this instead. The reality of how we use our language to ensure that our citizens have confidence, the AI that we use today in that clinical triage will, by the very nature of AI, be different tomorrow, the following week, the following month. And where we must go is take our patients with us on that journey such that they can see how things are getting better, as well as, and this is something the private sector doesn't suffer from, we have to take our clinicians and organisations with us. Because the NHS in and of itself is not a believer that the NHS can use and do technology. And so we've got a job to do in-house as well as with our citizens.
Yeah, and it speaks as well to that 80-20 that you talked about, doesn't it, Joe? So I know in Langston, South Cumbria, our practices are using triage tools for primary care, which now means that the people who aren't, like me, digitally enabled and using a tool in my, on my smartphone, they're able to get through at 8 a.m. or still get an appointment at 9 or 10 a.m. because those of us who are digitally enabled are able to sort of more self-serve. Mike, you sort of spoke to the other question that's in there around tertiary centres. Have we completed that? I think so. The question is, can AI help with GPs referrals to tertiary centres outside of their counties? So I think the bottom line with that was more that we need to get the foundations right, and it's not the AI. Was that your response to that one? Because I hadn't.
Yeah, I mean, it's a perfect example. Look, for decades. And there are both political and organisational reasons for this. The NHS has cut itself into lots of discrete parts, and its central organisation, particularly NHS England, has not been good at upholding standards which connect discrete parts of data and institutions, and secondly, using those standards to stimulate market activity, competition, and innovation. So everyone's gone off doing their own things with different bits of software. That has been a really bad policy choice for my opinion, for the last 20 years. Whilst the internet literally has demonstrated to us all the power of open standards and standard common protocols. So the problem about GP referrals to tertiary centres, or indeed anywhere else, is that the data pathways that referrals are sent down have not been set up right for the rapid sharing and receiving of requests. Now, can we use AI to sort that out? We probably could, but AI is not the answer to this. The answer to this is sorting out your central authority and having the strength and the rigor to use and uphold common standards. And those standards are not created by proprietary software providers. Those standards are designed by us in the UK for great public outcomes. And the market players are instructed to innovate and compete, but on the basis that they uphold a common standard. Now, for political reasons, in different parts of health, previous governments of the day would not do that. They felt beholden to key technology suppliers. That has to change because otherwise, what we're doing is we're trying to use emergent technology like AI to get round our own inability to make better decisions for our people and their public health outcomes. So, yes, we can put an awful lot of human ingenuity and invention into creating millions of workarounds using AI, or we could just solve the problem at source, which is our absence of a central design authority around standards and protocols.
And that lends itself really well to what I want to ask next. But I'm just going to ask Dr. Narayanan if you could possibly rephrase the question that you've put in the Q&A, because I'm not sure I understand it. So if you could maybe elaborate a little bit while I ask another question. So Mike, your opening statement was very much about interoperability and standards. And in Langston, South Cumbria, we've been doing a piece of work for 4 or 5 years looking at the Open Referral UK standard. So an open data standard for services, so third sector services in particular. And the adoption of that standard and interoperable tools that can interrogate a data set that's aligned with the standard means that health, local government, education from a SEND, neurodiversity perspective, etc., can all reuse the same data source for multiple purposes. So I can use some of the data, service data, to push to a COPD app, and it can surface on a SEND directory, and it can be used for commissioners for strategic commissioning. But that sort of an approach relies on system digital leadership. And obviously with the structural reform we're going through at the moment, ICBs in particular are likely to lose their digital leadership function. How do you think, either of you, we maintain a sense of inter-organisational system digital leadership if there isn't that sort of core hub in the ICBs? How do we encourage our sovereign organisations to work in a really collaborative way, and maybe even thinking about how do we procure in a collaborative way? Any thoughts?
Money. Lots and lots and lots and lots of money is at stake. Do the maths. So the problem is that system approaches whereby everyone is incentivized to use and uphold a common platform and standard and right to it means that the benefits of that are dispersed right across the system. The problem is our financial and economic modeling only happens in smaller units and smaller jurisdictions. So people say, well, how much money will this cost this year? How much money it cost next year? How much money will it save? The answer is it will save untold amounts of money systemically, but you have to have a different economic model to capture it and see where it is. So in the UK, when we done GovUK and we took 25 of the top services, I started with Treasury and I said, look, your business model, and you're doing the NHS, your in-year business model doesn't work for this sort of approach. And we mapped the value of transforming these services. And we took over 4.1 billion out of an addressable spend of 12. So it's like we took about a third of the cost out and got better services. Now, the NHS doesn't model its finances this way because all its jurisdictions don't work together on the financial modelling. That is a key thing that's got to be grasped. Like, what is the benefit if we all use the same stuff? What was the benefit if we all uphold the same standard and work to? But you can get a small amount of benefit in each place, but it's a systemic saving right across the piece. So the first one is follow the money. The second thing to do is even if you don't have a central controlling authority, which you sort of should have. But even if you don't have, in these cases, sort of Pareto works, because if you get enough people, if you get 20% of the people demonstrating value, 80% will follow quite quickly. And it's really a leadership challenge. You don't need everyone at the same time. You just need enough people with the bravery and resilience to connect and share, and that others will follow.
Fabulous. And I think the systemic benefits, I think, is key, but we're not really that good at sometimes measuring benefits in organisation, let alone across the system. So there's something about how we get better at that.
Well, that's been gained, right? You're not alone on this. Most sectors do. If you look at, say, like the first thing I'd say to people in the NHS is this, is that the issue you've just described and my answer to that, which is a militant view of interoperability based on common protocols and standards with the appropriate levels of financial and economic tooling to capture that. That is the same answer in lots of other sectors. So all of us live here in this country. If you're on the UK, you know the crazy situation with housing, whereas the land registry doesn't talk to the local authorities, doesn't talk to Rightmove, doesn't talk to Zoopla, doesn't talk to the estate agents. All of that data has to be swapped and changed, which makes conveyancing a horrible 3-month process. We could change that like that if we choose to. That is a political choice. We have not yet done that. I think we probably will. But internet era services, digital services that require scale, require this sort of systemic thinking. And the NHS is in a great position to go first and really grasp this. Because frankly, we can't keep just buying these big IT systems and hoping for great outcomes. It's not working.
Yeah, thank you. Joe, do you want a final word on that one?
I think I agree with everything Mike has said. The and for me is having absolutely clear leadership from the top, where it is a comply or explain situation. So actually there may be opportunities at some point where there is some amazing tech that isn't part of, but the reality is it's not the tech that's holding back most of the things that we want to do. So get on, comply, do as you're told, and the money will fall out. So completely agree.
Super, thank you. There was another question in the chat, which unfortunately we haven't time for, around risk appetite. So I don't know if either of you want to maybe type in a little response. So apologies, Charlotte, that we didn't get to that one. So that's the end of our webinar today. Thank you very much to both Mike and Joe for brilliant presentations and stimulating discussion. On behalf, oh, there's my dog. On behalf of BMJ Future Health, we're excited to announce that registration for our live event on the 6th to the 7th of November is open, and you can scan the QR code in the slide there now to visit the website, get further information, and book if you would like to attend. There is also another webinar taking place on Friday, the 31st of October, 12 to 1 o'clock. You can see it there, implementing digital tools to improve patient engagement and PPIE involvement in the NHS. And again, you can scan the QR code to book on that one as well. So finally, thank you to everyone who joined and attended today. We hope you enjoyed the session and look forward to hearing from you and seeing you in the future. And I hope you can't hear my dog.